So it's great to see everybody here. This is an amazing crowd. And I think everybody's super interested with all of the press around artificial intelligence and all the promise, I think, to hopefully bring this to patients at the bedside and affect care. And so we're gonna kind of talk about some of the aspects of bringing AI to the bedside throughout this talk. Just as a disclosures, I have some grant funding and then also some industry funding through Beckman Coulter, who sponsors a triage app that we utilize in the emergency department. I also wanted to say that I am not a very good drawer, so all these crazy images in here were all generated by ChatGPT. You'll also notice that one thing it does poorly is spell things within pictures. So just keep your eye out for those types of things. Okay, so in general, here's the outline what we're going to talk about today. I'm going to cover just some basic kind of overview and really try to kind of hone down on some of the really challenges and why you're not actually seeing more AI currently in existence. You would think there would be a lot of tools, but there aren't that many tools, and we'll talk about that. And then I'm going to start talking about MLOps, or machine learning ops, and why that's needed. And then we're going to move on from there to talk about just individual steps or key steps within that process. My hope is, because I knew this crowd was probably going to be diverse, there were going to be a lot of students, medical students that may not have had significant background in kind of the modeling process, to give a general overview within kind of the discussion of talking about MLOps. And then lastly, I'll just talk a little bit about the future of AI, MLOps, and medicine. Okay, so getting started here, I think we all know that there's a lot of promise in medicine. If we just start on kind of the right-hand side and talk about patient experience, the abilities for some of these tools now, particularly like large language models, to be able to facilitate educational components and diagnoses is quite remarkable. There's also been a lot of discussion and hope around reducing cost for AI models. There's both, I think, positive and negative aspects. You probably heard about the ability for AI models to help with equity and inclusion. One kind of interesting thing, and I think we've already seen this with some of the Epic implementations, is thinking more about team well-being, provider well-being, and doing things like kind of automatic filling out of charts and components for note writing. So hopefully that reduces our chart burden from that. And then I think most of what we think about from the standpoint of what AI has from a promise standpoint is actually changing healthcare outcomes and really at the population level. So I tend to kind of boil those down into two real factors and where kind of AI can help things. It's in decision support, and decision support is kind of all over. So that's at the patient level, the provider level, and then also automation. I think some of the tools that we've seen put in place already really are leveraging some of the automation piece. So mostly in like AI imaging applications. And I think we'll continue to see that moving forward. So I'm just going to, though, start with a story, because I think it's, we hear about different AI applications and the promise, and I think it's nice to kind of see a particular example and how that can happen in the real world. So this was a story that was given to me by Chris Tremera, who's one of our nursing champions and who's been instrumental in doing some work around triage in the emergency department. And one of his charges was, when we were initially rolling out the tool, to start to work with nursing around some education. And this story was given to him by a nurse who was working, and as we were initially evaluating the tool, it was a busy, chaotic emergency department, always is. It was around 5 o'clock in the morning. The nurse had been working 5 shifts in a row. She also had seemingly somehow picked up an additional shift. So she was doing a double shift. So she probably had been working like 16, 18 hours at that point, some ridiculous amount of time. And she gets a patient that comes in, and it's a 19-year-old who comes in with the sore throat. And you can imagine, it's 5 o'clock in the morning. It is like sleep time. For most people, particularly on an overnight thing. And she's sitting there, she's at triage, she's looking at this patient, And she says, oh, yeah, it's a 19-year-old, otherwise healthy person, just going to assign a triage level of 4. And that's for those people who may not know what this ESI score is. It's Emergency Severity Index. And it's a general reflection of kind of the operational use, in particular disposition use within the emergency department. A 4 means that they're really not that sick. 80-90% of people who are 4s go home. But what the nurse had failed to notice at that time, because she was tired, sleepy, whatever, and you would think that this would be a major component of triage, and it is, was that the patient had a vital temperature of almost 103. His heart rate was 130. His blood pressure was a little bit down, so it's a little bit hypotensive. And his respiratory rate, which 20 is like the common number, so it's probably higher than that. And so she had assigned that score without really seeing those vital signs. Now, the caveat to this is that when she was going through we had this algorithm that's running in place that is supposed to facilitate triage. And the way that this algorithm works is that it looks at past medical history, it looks at vital signs, it looks at chief complaint, and it also assigns a triage score. And the triage score for the Triage Go system had been assigned a score of 2. And it was that just little bit of kind of push that allowed her to be able to move the patient back quickly. The patient ended up having epiglottitis, had to be admitted to the hospital. And so, sometimes it's not a lot that can kind of get you to push you over. And this is kind of an example of one of those, from a decision kind of making standpoint, and occasion noise. She probably wouldn't have made this mistake 99 times out of 100. It was just that day where she was super tired, she didn't look at things. And I think AI has a lot of applications kind of in this area. So if AI has all of this promise, what are some of the challenges? Like, why aren't we seeing all of this all over the place? And I'll give you this figure that shows you the number of studies that have happened in AI in medicine in approximately the last year. So about 14,400 studies. So people are publishing on this all over the place. The problem is that if you look at the number of studies that are describing successful implementation in that year time frame, there was only 41 studies that actually describe some implementation efforts. So there's this massive gap between people just publishing models. They did this, they were accurate on this particular thing, and actually getting these models into the healthcare space and changing patient care. So we're going to talk a little bit about this implementation challenge and kind of where this gap comes from. So there's a couple of kind of challenges with implementation of AI in medicine. I think that personally, it's a problem of kind of lacking scale within our healthcare systems. And if I take two examples, or I'll probably just give you the one example of the kind of researcher, maybe it'll kind of sink in with you. So a typical researcher that's in this space, and probably I was very similar to this. You start with a project, you have an idea, you've identified some particular problem, you develop a machine learning model, maybe with your local data. It looks potentially for development of a clinical decision support tool that's integrated with the AI system. Maybe you get the funding, you use that funding to do some implementation locally. Maybe you get lucky after that and you convince the funders to do a larger implementation, a multi-site trial, and then you're kind of stuck. So the question is, where do you go from there? And that's on the kind of researcher side of things. On an industry side, they have other limitations. One of those is data quality and availability. Obviously, a lot of industry is not hooked in directly into healthcare systems. They also don't have direct integration with clinical workflow, so they don't have boots on the ground from that standpoint. And then there's other kind of more general issues. There's regulatory issues, there's technical limitations. A lot of this also has to do with clinical validation and trust. Do we have the right systems in place? And then perhaps one of the biggest things is this idea of kind of continuous learning and adaptation. So most of the time when these models are developed, they're developed once. They have their associated like coefficients that they've used for the learning process, and then people will try to do external validation and generalization out of there. But there's this kind of missing mentality that healthcare systems are local. The clinical processes are local. It is, things change all of the time. Data changes all of the time. And it's going to be really hard long term for us to take these general models and just try to apply them everywhere without moving back locally into the healthcare environment. So how do we address this kind of implementation gap and bringing AI to the bedside? So, I think there's a couple of support structures you should just be aware of and really start to think about AI in medicine as a service. So, very similar to your laboratory service, maybe even to like a clinical department. The first of those you can think about is from a development ops standpoint. So this is more of like the data pre-processing, but that can be for a lot of different things, not necessarily just for machine learning applications. There's clinical decision support components of that may not necessarily be directly tied into your machine learning people, but we'll talk a little bit more about those components. You need to have user interface teams. You really need to involve stakeholders. A lot of the challenges that people have faced in the past, a lot of the failures in AI applications so far have been because people haven't had boots on the ground trying to really understand the clinical processes behind that. You need to, as a part of that, you really need to understand clinical workflows and groups. And then you also need to, have government structures in place. But what I wanted to focus on here was mostly this kind of idea of MLOps. You may be asking, so what is MLOps? So it's machine learning operations. It's really like a software engineering kind of mentality to development of models in the kind of AI space. So it's generally applicable not just in healthcare, but we'll kind of go through that. And the idea is that you need to take good engineering principles and move that into the clinical space so that you can ensure data integrity, safety, and that you can also scale things out, that you can quickly develop models, that you can adapt models over time. And so, there's a couple of major principles behind MLOps. One of them is version control. I'm sure most of you have been given a Word document in the past, and you get it from one person, and then another person makes a modification to it, and then somebody sends you an email for another thing, and so on and so forth, and you're like, oh, this is crazy. Like, now I don't know what version I'm on. Definitely Google Docs and some other things are better for that with version control. So the same thing needs to happen in all of your life cycle for your machine learning development, not just from the model development standpoint, but from the data aspect of things, and so on, and to all the way into the deployment stage. So that's version control. You need to have good data management principles. I think when people start to work with data sets, they tend to do stuff to data sets. They do some pre-processing, then they move it into an intermediate folder. Maybe they do something else, and they move it somewhere else. And along the way, you may lose a particular data set that you had worked on previously. You may not know how you got there. So you need good processes that allow you to be able to, at each stage, to go back to the data set that you had. We'll talk more about model development and testing. There's also this kind of idea around continuous integration and deployment. And it basically means if we're really going to scale up these AI models in our systems, we need to be able to rapidly get them out. I mean, you may have 5 models in place, but people are thinking and talking about having hundreds or not thousands of models running for various different scenarios. That's the only way we're really going to see a significant effect. So we have to think about like how we're going to do that and build that into systems. As a part of that, there's the aspect of model serving, or getting those models out. There's monitoring and logging components to that, which is basically making sure that models are fair, and we'll talk more about those components. And then there's governance structures that need to happen around that, and all of that kind of gets wrapped in this life cycle management. And in addition to that, you need collaboration tools. You need for your machine learning engineer to be able to talk to your DevOps engineer, to be able to talk to the nurse that's working on the clinical floor, that's going to be involved in the project. So all of those things need to be kind of incorporated into one holistic framework. And what does that allow you to be able to do? Well, it improves your collaboration, you have faster deployment, you have better reproducibility, you have better scalability and reliability, efficiency and quality control. These are all things we would hope we would have out of AI systems. You can go back and audit. So if somebody made a change because you have good version control, you can go back and check things. And you're constantly working and continuing to improve, which fits kind of with those learning healthcare system models. And then hopefully by having this scale in this team-based fashion, you can reduce costs. It costs a lot of money if you want to make one model, but if you have a system in place where you can rapidly develop models, hopefully you get some economy of scale and cost reduction in that process. And there's a lot of, I've kind of mentioned some of these team members. I mean, so you can have data scientists, ML engineers, data engineers, software engineers. I think the general point of this slide is that it takes a large team to do these types of things. And most healthcare institutions do not have all of these in place or do not have enough of them to really scale out a lot of the machine learning and AI systems at this point. Okay, so we're going to start working through the MLOps workflow. And these are the components we're going to talk about. We're going to talk about project initiation. We're going to talk about some feature engineering components, both specifying the general requirements of that, and then also talking about just the pipeline component about getting to features that you can use in the ML and AI applications. We're going to talk about experimentation and model development. That'll kind of go back to the general thing you probably are most familiar with when people start talking about like machine learning. You can kind of go through the initial data processing, model validation and testing, and so on and so forth. One interesting thing that is definitely continuing to develop is this idea of automated machine learning, where a lot of the processes of even data processing, but definitely hyperparameter tuning and a lot of things you have to do in the middle are being automated so that it's bringing hopefully machine learning development to more and more people that don't necessarily have that expertise of knowing linear algebra and all those other things that you need to know. There's the other component of that is model serving, and how do we get these models out quickly into the environment. We definitely need to be able to monitor these models in place. If you have a model running, there's lots of bad things that can happen that can make that model start to perform poorly, and we'll talk some about those components as well. Okay, so starting out, we'll talk about project initiation and specification. If I had to say what was like probably the most important step in all of this, it's probably this step. You really need to know what your clinical problem is. There's a lot of ways of going about that and defining it. A classic way is to do design-oriented thinking around the problem to monitor process flows and workflows, and then really get kind of an understanding of the end user. It's definitely one way to approach that. Looking at economic analysis, if you get to the end and you don't think that you're either going to be able to improve patient outcomes, or there's a small chance because your machine learning model marginally performs better, you have to question whether it's even worthwhile rolling out. And then there's even some space for using machine learning to do some problem understanding in this area. And I'll bring an example just to kind of hopefully bring this home some. So you can, a classic example that was done because there was a ICU data set that was freely available that was de-identified, and a lot of people did various machine learning models on that. And one of the classic kind of problems that people would look at was clinical deterioration or death within the ICU in a particular time frame. And one of the things that you notice when people were developing these models and they would publish the results and look at the features that were involved with that is that a lot of the features that were coming out were already a part of somebody's clinical decision-making process. They already knew that they were deteriorating. So for instance, like if I update somebody's code status within the system, it's a pretty good indication that that it maybe something is changing, and it's not necessarily very helpful to the provider on the ground if you're using those types of features to be able to make your model. So the general point of this is that you need to really talk to those stakeholders and they need to be involved in that initial process so that you don't make those types of mistakes. There's this whole team of people that are involved in these processes, and we need to think more about how can we bring people together and be flexible and nimble when we're developing these projects. So the second component of this is thinking about your features that are kind of required for this. And this can be very simple to talking to your stakeholder and be like, okay, like I want to predict whether a patient's going to come back into the emergency department in 72 hours. Like what things should I be looking for? And it's a good place to start is talking to emergency providers, nursing providers, and so on. And things that you'll get, you would get out of this is, oh, well, actually one of the things that we would like to be able to do is to count the number of prior visits they've had, because that would think that would be generally predictive. That's kind of what we've seen from experience. So there's a lot of discussion that needs to go into kind of that requirement components, how you're going to do feature selection, what pieces of data are of good quality, which ones need to have some quality assessment to them, which ones, where you're going to have, how you're going to collect that data, how that data is collected temporally, because sometimes you can have issues where if the classic example is as notes. People are like, oh, great, we can use notes for everything. Well, if you document, 5 hours after a patient's visit, it's very, a note is not going to be helpful in making a prediction on that patient. So you need to know those types of things and understand the clinical environment before things are moving forward. And then, talking about scalability considerations as well. Can we move this into other areas is a big component. And the idea is that, what you'll do from this is you have your feature kind of set or requirements, and then you need to know where you're going to get that data stream from. As a part of the I would say every healthcare system has electronic health record data that they store in some database that's accessed for reporting structures and other things. You are going to have that data can be stored and utilized in some way, but most of the time you're also going to want to have some type of real-time data. So you need to kind of be able to break this up into different streams. Like in the emergency department, we can take past medical history, outpatient medications, all of those things that can be stored in a database. It doesn't have to come through real time, but things like, the patient's vitals when they arrive, their chief complaint and other things, those are going to be real-time streaming data, and those are going to come from potentially different sources. And then you may have outside, external data that you're using within this, or you may want to use. A good example would be like the Connecticut PMP, which lets you know about medications related to opioids and other things for general patients if you were trying to do some type of prediction in that space. So you get that information, and then from here, you have to think about your data connections that are going into this, and then the general transformations, what kind of cleaning, what type of imputation. This is pretty standard kind of machine learning processing components to this. You need to think about how you're going to engineer those features as they come through, and then this is a big part that I don't think often is thought about. So you've done all of this work to do lots of processing, lots of data quality assessment and cleaning. To really effectively leverage that information, you need to move it into some feature store system. You need to store those features so they can be used for other patients. So you can have reproducibility, so you can scale out to other applications. I mean, the vast majority of cases in the emergency department, we probably would use 90% of the time the same feature store of kind of classic features. So, outpatient medications, laboratory information, vital signs, and so on and so forth. And so, having that available and to being able to move that quickly into production space can be super helpful. And most systems aren't really storing these types of feature stores and utilizing those very effectively. And then there's the model development stage. from this aspect of things, I think, probably a lot of people have general experience in this area. So exploratory data analysis is definitely a component of this. That's where you're going to figure out, how much missing data you have for available things. There's, the data preparation and validation process where you're kind of further cleaning, you're setting up your target outcomes and your features. And then there's the model training component. A big component now of model training, and I would say 5 years ago, people weren't really thinking like this, is making assessments for fairness within the models, trying to think about explainability components within the model, and all of those need to be incorporated into the pipelines almost on an automatic basis so that you can really scale out. Other components would be the model validation. Do you have different ways of doing validation? Are you using external sites? Do you have internal sites that are separate and may have different data components or features? And then finally, you'll get to the ability at some point to kind of do some export of the model. And so the general process is, as you're going along through all of that, there's going to be multiple team members that are going to be working on these things. They may each have a different component that they're working on. And you need to have a kind of a record of all of those processes that have happened during that. Hopefully this works. I'm going to see. So the one kind of, I think, good example of a way to keep track or have a nice store of what your models are is these idea of model cards. These are developed by Google, but the general idea is that you have a card that kind of summarizes the model in various different ways. It'll tell you about the general clinical problem that was developed, what data sets were used, what features were potentially used, and where those feature stores may be, the general performance on it, what may be the problems around that. So you can just see kind of how this breaks down from the kind of model component here. So they have limitation sections and other kind of areas and like this. So ideally within a healthcare system, you would have for each model that you had within your system, you would have one of these model cards available that you could go through, and that they would also be continuously updated as you did new integration and deployment measures within this. Let's see. That was a good transition. Okay, so we'll talk about just some of the model management components, because I think this is where some of the MLOps part comes in, where most, if people are doing kind of just a side project and doing some ML development, they may not integrate some of these features. So there's in MLOps this idea of versioned artifacts, and basically you're keeping count of kind of all of the different components and things that are being developed out of the kind of ML cycle or process. So that includes both the model, it also includes the ML training process, the general code. So we talked about versioning earlier. All your code needs to be versioned so that you have a complete store and what's being changed. That allows you to be able to audit things moving forward as well. And then there's just general workflow orchestration. How can you switch in and out models? What model registries do you have? This is also would be where you have your kind of model cards stored within this space as well. And all of that allows you to be able to do better continuous integration and deployment within this framework, to move faster, to be able to push these models out in a more scalable component. And what does the deployment look like? So for, I think a lot of times when you're developing models, we kind of work in this batch framework where you have taken this large cohort of retrospective data, you've split it up into most of the time a training, a validation, and a test set, and then most of the time after that, people are kind of stop if they're not really getting to the point of actually deploying or using the model in production. Moving to that stage, there's some additional things you have to think about in the way that it's organized, in the way that the data is coming in and the inputs are set up. So you just have to think about how you're going to develop those endpoints, how those are hooked up within the system as well. A big component of this is model monitoring. And this is one of my fears when we have AI systems that are in place, even from the industry standpoint, is how effective we are at doing monitoring on systems that are coming in from external sources. There's lots of, as I mentioned before, there's lots of kind of bad things that can happen. So one thing is that your population can just change. You know, something happens, there's movement in and out of your population. That's this idea of data drift, where you have these distributions. You know, your age population changes over time. You know, if you had models that were looking at respiratory issues during COVID, you would have had, you know, significant changes within your model structure, and you would need to be able to monitor those things continuously. Data quality can be an issue. There's always upgrades that are happening within the EHR system, and you know, any day somebody could turn off a particular component that was being used as a feature within your model, and all of a sudden your model is, you know, less performant than it was before, and sometimes you even break the model. Prediction drift is also just this idea that you have shifts in your prediction over time. A lot of times it's a result of those components. And then feature attribution drift is this idea that, well, your model, you know, if you're in this kind of continuous development and deployment cycle, it could be that your model started with certain feature weights that, you know, use, let's say, sodium values pretty heavily within the model. And then over time, there's shifts that happen with the way that the weights are distributed within the model. That's, you know, if it's a lab value, not too big of a deal. But if you're talking about like sensitive attributes, like sociodemographic characteristics, that's something you really want to pay attention to when you're going through this process. And then I just kind of brought this piece in, which is this automated ML aspect. And really, it's just this idea that like all of those previous steps, or a lot of those previous steps, can be wrapped up in their software that's involved in being able to do a lot of those steps automatically. What it allows you to be able to do is to automate some of the ML tasks. Hopefully, it's more accessible to non-experts in the system. You gain some efficiency.
This one?
Yeah. That's good too. Okay.
Is this one still?
Can people hear me now? Okay, online? Yeah, okay, great. Okay. So what I haven't talked about is, because we just don't frankly have enough time, is talking about all of the other components that I had kind of mentioned initially. So, you know, most of the time these models are built and they're in service of getting to some type of, you know, clinical decision support system. And obviously, there, you know, those people that are involved in that, your human factors engineers, your clinicians, and everybody else need to be a part of that. And so there's, you know, as a step of this, you need to have kind of a scalable system for integration with clinical decision support systems. Interesting. Oh, there we go. Okay. And then those systems then need to be integrated within clinical workflows, and you need to have kind of systems and processes that allow that to be able to happen. So this is just a clinical workflow of just looking at OUD management within the emergency department, but you really need to be able to understand like how that clinical decision support tool associated with the AI product is going to be integrated within that. And you need to have a system that's going to allow you to be able to scale up those components as well. So what are some of the challenges and some of the pitfalls around this? I think, you know, the main thing around this, as far as like why are healthcare systems not doing this, you know, currently is there's a resource issue. So it's not cheap to have all of those engineers working in the background. My hope is that as we see more and more AI applications. We see the effectiveness of AI applications, and it becomes more cost effective to have these types of teams. But sometimes it's going to take, a leap of faith to move to the scenario where you really are considering this like a service-oriented component to your healthcare system, and really starting to make that investment so that you can move things forward. It's always going to be a challenge to ensure fairness and safety within these. That's why you have all of these components in place. That's why you follow the versioning and make sure that you have good software principles in place when you're going through this. And then another big challenge with this that I see in the opportunity really for like disparities across rural and academic urban kind of environments is this idea of like training data. And so as I mentioned initially, one of the big ideas behind this is that your kind of development of these models needs to happen locally. There's so much change that's happening within your system. It's going to be really hard to just buy an off-the-shelf model and not do any validation within your system and not continually monitor it over time. For Yale, that's one thing. For a small community hospital in my home state of Mississippi, that's going to be a very difficult thing to do. In addition to that, they're not going to be able to generate a lot of data around their patients to be able to kind of make inferences on rare conditions and things. There are ways to get around that with aspects of training, transfer learning, but I do worry that we're going to get into a scenario where large kind of academic institutions and large healthcare systems have these types of models in place, and then there's smaller kind of rural systems that aren't going to really have these available to us. So just to kind of wrap this up and just to talk about some general takeaways. So hopefully you got just a general picture of kind of the process behind development of kind of AI systems, particularly when it just comes to kind of the machine learning part of that. Hopefully now you kind of understand why MLOps are needed within the system. And it's really in service of that kind of moving things to a scalable solution in the future. Hopefully you got some idea about the key steps around that process. And I've talked a little bit about the future of AI. My hope is that we will continue to kind of expand these types of services within healthcare organizations so that we're able to really kind of leverage these products as they move forward, and that we're able to actually study them and make sure that they're safe when they're being implemented as well. So I will stop there now and just allow for any questions, but otherwise it was great to see everybody here. It was great talking about this as well. Thank you all.